Welcome, everybody. It's my pleasure to welcome you all to today's meeting to discuss critical NPD challenges that can be addressed through operation research. I welcome all the presenters, guests from all over the world who will come to share their knowledge and vast experience in this field of NPD. And next slide, please. With us here, we I'll be moderating together with Dr. Laura. Then there'll be three speakers actually. We'll be having Dr. Kabona from Tanzania, Michael Kirumba, who's the Deputy Director, Accelerate Program Site Savers, and Technical Manager, Washington NPD Site Savers, Samuel Kashtem. And together with Dr. Laura Senenjo, who's the Deputy Director of the Epidemiological and Investigation Unit at Site Savers, and myself, I'm Michael Retitu, Trachoma Coordinator, NPD Department, Ministry of Health, will be moderating this session. In today's session, we'll be having a definition and global overview that will be taken by Dr. Laura. Then we'll also have findings from the operation research in Kajiado that is ongoing. Michael and Samuel will have a presentation on that. Then cross-border approaches and how we are managing migrant population between Kenya and Tanzania. We have Dr. George Kabona who will give us a presentation on that. And after that, we move on to the breakout session discussions and come back and reconvene for a plenary and have a group discussion. So we are going to the lower part of your PC you're using. And you put your hand up. First question is, who is involved or supports a country program where there's persistence of any NPD or any NPD is an issue and is persistent? Raise your hand, and you still leave your hands up if you are involved or support a country program where PF, trachoma persistence, is an issue. And you can please note the name of the country in the chat. Thank you for all that I can see their hands up. I can see also in the chat names of countries. Thank you all. Okay, I can see Ethiopia, South Sudan, Kenya, Ethiopia, Nigeria, Tanzania, Uganda, Nigeria, Cameroon, Tanzania, basically a wide variety of countries are experiencing persistence. And so I'll, at this point, hand over the baton to Laura to take you to the next session of these presentations. Thank you, Laura.
Thanks, Titus. So yeah, next slide. So I'm just going to make sure everyone's on the same page. I do appreciate that another session did very similar slides, but I just want to make sure that those who weren't in them just kind of are aware of what the definition of this is and what the global is like. So persistence is basically where we've got districts that have 2 or more trachoma impact surveys in which the prevalence of TF in children aged 1 to 9 has never been below 5%, and of course it's above 5% at the moment. And that's opposed to recrudescence, which is defined as where the result of 1 trachoma surveillance survey has come back greater than 5% of TF in children aged 1 to 9. And again, the current prevalence is above 5%. Next slide. And this is just basically a word cloud representing which countries have been identified by ITI in having at least one district fitting the definition of persistence. And the bigger the country is, the more districts that it has on that list. You can see Ethiopia is meant to be highlighted as the biggest because it has the most number of districts where there is persistence. That's a problem. So as also, you know, there's been a number of options that have been mooted around how to deal with persistence and actually recrudescence. And it ranges from things such as really kind of a deep dive to really understand what are the reasons for persistence, looking at the enhanced investigation, looking at alternative indicators, really understanding whether there is true recrudescence or persistence. Is it really trachoma? And if it is, better understanding transmission dynamics, looking at what can we do better around actually doing programs differently or delivering programs differently, and how do we target those changes to make sure that they make most effective. Then looking at other options around MDA strategies, including more than frequent than annual MDA, and finally just do nothing, just wait and see what happens. So next slide, please. So I'm now going to really pass to the two presentations, which are outlining the approaches taken in Kenya and Tanzania. And this is really much more looking at in-depth look at what's been done and what have been the success challenges for them. So there's two presentations. The first is a bit longer than the second one. And then after the presentations, we'll have time for questions before we go into some breakout groups. So first, I want to welcome the presentation by Michael Karumba and by Samuel Eshitemi from Sightsavers. Thank you.
Hello, everyone. My name is Michael Kirumba. I'm working at Sightsavers. And in this COR NTD session, we're going to present on persistence and recrudescence of trachoma and sharing our examples and experiences from Kajiado County in Kenya, where we've been leading some operational research to inform programmatic adaptations. So with me in this session is my colleague Samuel.
Yes, how are you? My name is Samuel Eshitemi. I work for Sightsavers in Kenya under the Kenya Trachoma Elimination Program. Welcome.
Thank you, Sam, and please move to the next slide. So in this slide and the next one, I will not dwell so much on that. You'll have an opportunity to review at the end. They talk about the sessions as well as the objectives of the operational research. So where I wanted to focus is on this process of what entails a deep dive or investigations to look into persistence or recrudescence of trachoma. So based on our experience in Kajiado, we applied the use of a checklist to look at epidemiological issues, programmatic performance, as well as socio-demographic factors persistent or relevant to the community in that area of persistence and recrudescence. This also entailed looking at past MDA reports going back all the way to 2004. Lots and lots of interviews with key informants from the ministry, from the Kajiado County itself, from the partners who were involved in the implementation. And then during the actual implementation, we had impact surveys or enhanced impact surveys, where we collected additional indicators for chlamydia trachomatis infection, as well as antibodies. And then during after MDA, we would do coverage evaluation surveys to obtain community feedback on the experiences with the MDA, as well as to be able to validate the performance data that we get from during the or in the administrative reports. So this whole process is repeated every 6 months. Next, please. So Kajiado, this is the map. And some of the key things I wanted to mention is you can see on the northern part of Kajiado, there's Nairobi and Kiambu. These are sort of the very high population areas. And you can see that because of the very high population and the density of the areas, they tend to push some of the communities to Kajiado. So Kajiado, you would see that this is Kajiado East, where you see Kaputei North, Imaroro, Kenyapoka, that's Kajiado East. And parts of these areas, as well as Kajiado West. In the north here, you can see that those form what you call the metropolitan area of Nairobi. On the western part is Narok, and the southern part is Tanzania, where we have the Longido and Ngorongoro districts. So these 4 areas, the 2 in Kenya and the 2 in Tanzania, form what we call the Maasai Corridor. And it's where we have this contiguous Maasai community, in which context the border is sort of non-existent because of their movements. Next, please. So in terms of the trachoma context in Kajiado, I think trachoma has been there much longer than 2004. What you're showing here, 2004, is a documented history of trachoma in Kajiado. So in 2004 was when the Ministry of Health conducted baseline mapping of the disease, not just in Kajiado, but within a few other districts. And in 2007, a comprehensive trachoma elimination program started. And you can see that at baseline, trachoma prevalence, TF prevalence was at 28%. And through a number of rounds of MDA, it reduced by 2011 to 17.5% when an impact survey was done, which showed that they needed to continue with a few more rounds. And after 3 more rounds, they did another survey in 2017. There was a delay. And at the time, it showed that Kajiado West had still not managed to bring TF below threshold, while the other 3 EUs had managed to bring it below threshold. So when the follow-up surveys were done in 2020, you can see that all the districts came up above threshold, including Kajiado West, which meant that it now fulfilled the criteria for being considered as persistent, or an area where TF is persistent, while the others had the definition of areas where TF is recrudescent. So it's at this point that we started talking about doing operational research to understand reasons that could be driving this persistence or recrudescence. So rather than implement additional MDA rounds, let us dive a bit deeper into this. And you can see on the right some of the data you're seeing there, the 18% and so on. This was the data we collected at baseline prior to the beginning of the operational research. Next, please. So what you see here are the alternative indicators that I talked about at the beginning, one on CT infection and the other one on antibodies. So the one on CT infection, what it's telling us is that trachoma is definitely not a public health problem in Kajiado East, while in contrast, we've had also strong evidence of infection and ongoing transmission in the other 3 EUs, so Central, South, and West. But it's also important to note from this data that Kajiado Central and East have very differing trachoma transmission indicators. Yet, in the past, since the very beginning, we've always lumped them together. Next, please. So in this slide, you're able to see the seroprevalence curves, and these are proxies for transmission rates. So in Kajiado East, we see a flat line. This is on the right, on the extreme right, and this is evidence of very low transmission. And this is similar to what we've seen in other elimination settings. And conversely, we are seeing steeper curves in Kajiado Central, which is indicative of a greater force of infection. And what is also very interesting is the seroprevalence in Kajiado South and Kajiado West is lower than would be expected for the level of infection that was identified. But the seroconversion rate, on the other hand, does further indicate that there is definitely ongoing transmission that requires continued interventions. Next, please. So I'll not dive into this, but this is just kind of a snippet of the results from the coverage evaluation survey, which, as you can see, either confirms or disputes the data that you have from the administrative MDA reports. Next, please. And on this slide, you're able to see the qualitative feedback in 4 themes from the communities in terms of their experiences with the MDAs. And just to take 2 is to see that they're really asking us to enhance door-to-door distribution, which is not surprising looking at the size of the county as we saw in the map, as well as how sparsely populated it is, meaning that people maybe had to walk long distances, and also asking maybe for greater use of CDDs, because these people are known to them and bring the drugs all the way to their communities. So I'll hand over at this juncture to my colleague to share the programmatic enhancements that we adopted. So over to you, Samuel.
Thanks, Michael, for that great presentation. I'll now take you through the programmatic adaptations, and this is as a response to the gaps that came out from the operations research. One of the gap was around weaknesses in support supervision, and as a response to this, we developed an e-supervisory application that was given to the ward supervisors and the sub-county level supervisors. And as you can see on the left, this is a map showing where some of the supervisors have been to. So with this application, we are able to pick out where each and every supervisor has been and how many teams they have visited. And if we note that a team has not been visited, then it is possible for us to recommend that support supervision be given to that team, and a supervisor is assigned to ensure that the team is visited. Additionally, on the e-supervisory app is the real-time monitoring of coverage. So what happens is all the data are supposed to be transmitted from the field to the EU level, so that then decisions have to be made. And previously we had challenges because this was paper-based, and getting paper-based data from the field up to the EU level was problematic, and they didn't get on time, and it was not easy to make decision, for example, on when to stop MDAs before the data could reach the EU level. And as a result, MDAs were stopped way before coverage rates were achieved. The other programmatic adaptation is around one of the gaps that we noted, especially not being sure if we were leaving specific pockets of people behind, because we note that in some areas, even within EUs that are reporting lower coverages, we have very small pockets that are showing very high TF levels. And so to be sure that CDDs were reaching each and every community member during the MDA, we have come up with a GIS tracking application that monitors the movement of CDDs from one particular household to another. And this data is then available to the supervisors at the EU level on real-time basis to make decisions on what they'll be obtained. As you can see on the key on the right, showing some places indicating that they were visited and people accepted to take drugs. Others, they were visited and people didn't take drugs. But still others, the CDDs went there and people were absent. These then just going to confirm the migratory pattern that is being experienced within this nomadic community. But good to mention that other areas that have been identified to have been missed by the CDDs, then the supervisors recommend that an action that these areas be visited, because they are able to identify them on this interactive map. And one of the things that we also noted earlier on was that because previously MDAs were led by a frontline healthcare worker, some of the MDAs started very late and maybe ended early because these health workers had other responsibilities to perform at the health facilities. And as such, through the CES, as recommended by some of the community members, that they needed to have people they know and trust from their communities to be giving drugs, then we did ensure that all MDAs were led by the CDDs. Another enhancement is around the issue of cross-border. And as a response to this, we are strengthening our cross-border planning and implementation with our counterparts in Tanzania, and ensuring that we synchronize the period when MDAs are conducted between the two countries and ensure that it is at almost the same time, so that no one is missed at any MDA campaign period. The other thing we noted was very poor coverage at urban and peri-urban areas, especially after what Michael has indicated, that Kajiado County borders Nairobi City County. And because of this, we have an influx of people working in Nairobi, residing in Kajiado. One of the things that we noted was there is a high social media preference among these people living in urban and peri-urban areas. And so we are working with our partner in Kenya, iFluence, to ensure that these people are then reached by social media for them for these areas to have an increased uptake in the MDA. And as you can see on the right is a screenshot of one of the social media campaign that was launched through Twitter. So what then do we recommend that should be considered? In this handout, you will receive some of the challenges and lessons that we have learned. But because of time, I'll just deal with what you need to consider. One, when you are planning for a deep dive, you need to ensure that you have in place a human resource that has the capacity to conduct the exercise, because this will involve a lot of document analysis and synthesis. It involves a lot of interviews. It involves a lot of research work, especially when it comes to the CES and other things. And so these capacity need to be in place both at the national and the regional level, or else you end up being overstretched. Number two, you need to allocate adequate funds for the deep dive and the programmatic enhancements that follow. These programmatic enhancements require some heavy investment, not just in money, but also in time and also in capacity building. So you need a lot of funds in place for you to delve into them. Another thing is that you need to ensure you are working very closely with your Ministry of Health and the local Ministry of Health, because their buy-in and their involvement is key to the success in the whole process. You need to ensure that you have prior capacity in place for the analysis of the samples that you are going to collect, because without this capacity, then you will need to put in place mechanisms of how your samples will be analyzed, maybe in a country that has capacity to do the same. And as such, you need to prepare to obtain all the ethical clearances on time, so as you are not caught off guard. You also need to prepare for some external risks and be flexible that you are going to experience some challenges. For example, we did experience challenges in securing materials for analyzing laboratory samples because of COVID-19 challenges. And we had to put in place measures to ensure that the samples we collected were able to be preserved until that time when we had all the materials that we needed for the analysis of those samples. So this is very important for you to put into consideration. So thank you very much. That has been our presentation. We would like to thank some of our partners, including Kajiado County Department of Health Services and Public Health, who have given us an opportunity to work in Kajiado, the Ministry of Health in Kenya, who have been very key in supporting us throughout the process, and our laboratory partners, that is the Kenya Medical Research Institute and our CDC Atlanta, who have been supporting us in the lab analysis, and our partner IFENS for leading us in the social mobilization through social media. Thank you.
Thank you.
Bye.
Thank you so much for that great presentation. So the next presentation is by Dr. George Kabona from the Tanzanian Ministry of Health.
Hello, my name is Dr. George Kabona, the National NTD Program Manager from Tanzania mainland. And today I'm going to share with you the cross-border approaches which we have been using to manage the migrant population in the trachoma endemic district. Tanzania trachoma elimination program is very successful. We have managed to achieve elimination in 67 districts, and we are currently remaining with the only 10 districts with a population around 2 million. And these remaining 10 are actually the one with problems because 5 of them have the persistent infection and 5 of them has recrudescent disease. Looking at this map, you will see all 9 out of 10 remaining districts are connected to each other and they are clustered along the 3 regions, the Manyara, Arusha, and Dodoma, which makes them a very unique feature and suggesting probably we are dealing with a population with the common features. Before developing these approaches, we were conducting the program assessment in the past during the variety of methods, and through that we are able to identify many challenges, but the key challenges among them on programmatic implementation include these areas which are remaining. They both showed a history of high baseline prevalence and they at least failed impact or surveillance assessment ones, and most of these communities are nomadic pastoralists, and there are some element of cross-border migration in Ngorongoro, Rongido, and the Monduli districts. And we had moments of low coverage before the year of 2017, and there are signs of low access to wash in these communities. Following WHO approval for modified strategies, Tanzania managed to develop the 2 main approaches. The first one is conducting more frequent than annual MDA, that is biannual for 3 years in Ngorongoro and Rongido, and for the remaining 8 districts which were eligible for 1 round of MDA, we'll add 2 more additional rounds before we conduct the impact survey. Now, on top of those strategies in Ngorongoro and Rongido districts, we pair it with a synchronized cross-border MDA with Kenya, and also scale up the Maasai BCC strategy and continue micro-planning at ward level and includes wash and One Health sectors individuals in these micro-planning sessions. But we are also conducting the implementation operation research, which is popularly known as mobile migrant population study, to collect the data and the informations to refine these modified strategies. Why are we doing the more frequent than MDA? This is just to provide ourselves opportunities to reach the nomadic population, but also increase antibiotic pressure and therefore increase the probability of achieving an infection of less than 5% and sustain the elimination across Arusha region. We are including the wash and the One Health sector individuals so that we increase the programs understanding of migration pattern and also address the low wash access for migration for migratory populations. We are aligning the MDA so that we allow ourselves for adapted impact assessment when we come to an end of the implementation of these modified strategies. Now, on implementation of these modified strategies, particularly those mobile migrant population, we know the reasons for persistent infection among these communities include the presence of mobile and migrant populations. Researchers have identified migrant parasites, namely as Maasai, is key must-reach population for trachoma endemic disease along the Kenyan border. And many of these diseases, as we saw earlier, have low treatment coverage. Now I will discuss these interventions under the mobile migrant population because this is a study which asks itself, how can we better reach this mobile migrant population with the MDA by altering standard programmatic implementation methods and enhancing the study coverage evaluation survey. We have 10 remaining endemic districts, and out of those 10, the mobile migrant study will focus on the 4 districts which are close to the Kenyan border. As you can see from this map, these are the 4 districts of Longido, Ngorongoro, Monduli, and Simanjiro, which are very close to the Kenyan border, and the study will focus on strengthening the intervention in this area. The area of focus for this mobile and migrant population study will be on strengthening the micro-planning in these 4 districts, and also conduct the TF monitoring by conducting the trachoma grading, collecting the ocular swabs, and also the dried blood slides at 0, 6, and 12 months of the implementation. And during the MDA round 1, we recruit more Maasai community drug distributors and also support them with electronic data capture and additional supervision. Another area of focus is after the MDA, we conduct the coverage evaluation survey, which will be accompanied by trachoma grading again, and also a qualitative data collection through focus group discussion. During the second round of MDA, which is planned to be conducted in February, we'll conduct the MDA only. And in the future, we are planning to look what to do with the new samples. So far, we have managed to conduct the first round of MDA during July 2022. And before this MDA, we managed to conduct the micro-planning in 18 wards of Longido districts, and also swab correction for ocular swab correction, trachoma grading, and also dried blood slide correction. And during MDA, we managed to recruit more Maasai community drug distributors and support them with electronic data capture and also enhance the supervision. Just to share one of the examples of the success story for the mobile migrant population study is that on the use of electronic data capture, which actually the aim was to timely do the mitigation to improve the MDA coverage. We managed to identify 5 communities which had poor coverage at the mid of the survey, and using a supervisor, we conducted the mitigations, and finally we managed to achieve the coverage above 80% in these communities. During the MDA, on cross-border MDA in implementation, strong engagement of all stakeholders was very important. That means including the Ministry of Health officials, partners involved down there, the local government, also community members during the planning and implementation. Frequent joint preparation meeting between the 2 countries with the composition of all above stakeholders was also key. And during this meeting, we discussed also the supply chain issues and make sure that we have the drugs and the other materials needed in the communities. Synchronized community sensitization messages, which are the similar messages from both areas so that we achieve the same intensity of social mobilization. But we also targeted the political buy-in by launching this synchronized cross-border MDA in Kenya, and we were able to invite the high-level ministry officials in that event. The other key learning is that we need to conduct the joint learning session after this MDA, also so that we can develop the lesson learned and use them in the subsequent MDA. But also, we noted that drug and logistics are critical path departments for the successful MDA. Social mobilization should be a continuous activity, and the engagement of the community leaders is instrumental for the successful cross-border MDA. One of the main challenges for this mobile migrant study is the limited resources. We wish we could conduct it in 10 districts, but now we are conducting it in 4 districts, probably even less than 4 districts because of the limited resources. We believe whatever we are implementing now, it will take us to identify or inform us on identifying the appropriate strategies to address the cross-border issues with minimum cost but maximum impact to the infection. Thank you. Hello?
So thank you very much for the presentations. I think Titus is just going to facilitate if there's any questions that people would like to ask any of the presenters at this point before we go to the breakout.
Thank you, Laura. At this point, I think we are open for any questions from the 2 presentations. The first one from Michael and Samuel, the one from Kabona. Can just raise your hand and ask. There's Martin. Go ahead.
Yeah. Hi to everybody there. I put that question already in the chat, but I'm curious whether because you mentioned One Health, but I haven't seen any evidence from these presentations whether you have actually used or started building One Health platforms for joint intervention, because this appears a particularly useful approach for these communities. So maybe there's some advice on what has been done or what's planned to be done in this direction.
Yeah, to Moses or Dr. Kabona, no, someone, whoever would want to jump in on that question.
Yeah, Titus, thank you. I think this is directed to Dr. Kabona.
Okay. Dr. Kabona, if you're with us. Dr. Kabona, if you're with us, maybe you could just unmute and answer the question on One Health platform. Martin has asked and feels that we are not using the One Health platform in our interventions. But we'll just keep that and maybe get a hold of Dr. Kabona, who may just answer the question in the chat. I've just seen it in the chat as well. Any other question?
If there's no questions, I might take the field, if that's okay, Titus, and just ask Samuel. I think sometimes there's some assumptions going into some of these investigations about why there is persistence, and then I think the deep dive investigations really bring out surprises. It might validate some things, but it will bring out unexpected issues. And the more you look into things, the more things kind of spring up. So my question to Samuel is what happened in Kajiado? Was there any surprises or unexpected findings, and how have you adapted to that?
Thank you, Laura, for that question. I think our experience in Kajiado has really taught us a lot since the time we started doing the implementation. One of the major highlights of our experience in Kajiado has been the issue around having Kajiado Central and Kajiado East being evaluated as one unit. And I think when we were doing the DBS and city data analysis, one of the things that is coming out is showing us that Kajiado East really has very low infection, number one, and also the TF levels appear to be very low. And by combining it with Kajiado East, with Kajiado Central during the evaluation as one evaluation unit, we might have been masking the effect of the TF levels in Kajiado Central, because it appears that the levels in East were bringing it low, and we might have thought that maybe after the first impact assessment that was done in around 2017 that showed that the levels had come up high, and we thought this was recrudescence. We are even thinking that it might not be recrudescence, but just a missed persistence that was there all along, but we didn't notice it because the areas were being evaluated as one. So that has been one of the interesting findings. And I think there is now talk and consideration of seeing that these two need to be separated. And going forward, I think even when it comes to now making decisions on providing MDAs, East, we have stopped interventions around MDA. We are only continuing with Central, and this is based on what we are getting from that. So that is one of the major things that I think I'll mention that came as a surprise, and how we've responded to it. Thank you.
Thanks, Samuel. So I think if there's no more questions, I think we can move out to the breakout discussions. The next slide is just highlighting the two topics. So there's two breakout discussions for two breakout groups. The first is really looking at what investigations or processes we need to undertake to effectively understand factors contributing to persistence of TF. So this whole deep dive investigation, what does it need to consist of? What should we be looking at? And the second is, what does the enhanced MDA look like, or what needs to be considered? So kind of around the MDA, what supervision structures, looking maybe at monitoring coverage, the reporting, etc. How really kind of understanding what we need to be looking at and what's going to be useful to respond to persistence. Then we'll have an opportunity to come back and share the discussion groups. I think you're going to be automatically put into one of these two breakout discussions. Bear with us a second. So just say thank you very much for engaging the breakout discussion. There were two kind of questions that were being looked at, and we'll just kind of give a very brief feedback on what the thoughts were around those different. Lost the PowerPoint.
Laura, let me start. We had healthy discussions on the second question, both on pre-MDA during the campaign and after the campaign. As you can see from the retro screen and the breakout two, more points came out during the pre-MDA planning. Members felt that it's good we raise awareness through social media and other traditional health avenues, kind of get the populations aware of the process and get the numbers during the MDA. We also discuss issues on digital micro planning, and again, communities came in to One Health, which Martin described briefly on where we give the communities the driving seat, and timing of the MDA is important, and also the education of that MDA through the One Health approach. And during MDA campaigns, again, St. Camel said first was use community members to lead the MDAs, also involve One Health in doing this, and adapting new and available technologies to help in micro planning, drug logistics, and reporting. You get real-time reporting that can enable you to conduct good micro mock-ups if need be, and also get coverage real-time. And last but not least, we had a few points on MDA where members gave some suggestion on tracking these populations and investing in the same, and also develop tailor-made approaches to subset of populations like these populations that are chronically missing out, non-participatory group, through inclusive approaches. Those are some of the highlights that came up to the discussion in the breakout session.
Thanks, Titus. And I think also then, just to give some points that came out from the looking at investigation of processes we need to undertake to effectively understand factors contributing to persistence of TF. I think the first kind of look was really having a tool that is able to really find the root cause of persistence. What's the factors that are driving it, whether that's epidemiological, programmatic, or external, but it's not too resource intensive to implement because it becomes, it should be program led, it should be program reflections, but it's getting that balance between the two. And I think that's something that we've got experiences from a number of different programs now across different tools. So it's good it'd be good to bring those tools together, see what's worked, what hasn't worked, and which one, where it can be maybe combined to kind of a tool that is user friendly and program friendly. So I think that was a good point that came out. Really understanding whether there is true trachoma persistence is important, or recrudescence. Is it actually down to trachoma infection and transmission, or is it something related to sampling error or artifact, or is it other issues with the TF as a diagnostic tool? So I think that was kind of really kind of main parts, looking at historical MDA coverage and survey data, and looking at looking at where there might be sorts of suggestions of baseline prevalence was very high. That's more likely to potentially be a risk factor for recrudescence. And then some of the programmatic investigations we looked at in particular was things about the target population or denominator, and therefore the importance of having something like maybe like a coverage evaluation survey or more independent verification or monitoring of coverage is useful, especially where you've got challenges around population. But understanding that better and understanding migratory patterns better, and having a tool that can help in looking at that. And then understanding WASH, and perhaps something that's not been looked at massively or not being touched on very much within the presentations, kind of issues around WASH, of course, and the importance that will have in transmission. So much more looking at geospatial breakdowns of different areas around coverage, around prevalence, and also by looking at WASH, and maybe triangulating them would be quite a useful way of kind of really helping to target where these enhanced MDA strategies might need to take. So I think that was the summary of the two groups. Thank you so much for everyone's participation. Is there anyone or any thoughts or comments or suggestions or anything in the chats that anyone would like to just reflect on at the end in terms of a way forward, or if there's any burning operational research that people think hasn't yet been captured? is there anyone would like to just add any thoughts at the end? Or I think we may be done. Titus, would you like to add any more?
No, I think I've exhausted all. I'm good.
Great. Well, I think then maybe just say thank you very much. Thank you for to Titus for helping to moderate. Thanks to the facilitators, and thanks also to everyone who presented and helped with the organisation of the session.
Thank you. Bye.
Thank you.
Bye.